There is good news and bad news in reference to breast cancer. The good news is that the death rate from breast cancer has dropped a whopping 43% from 1982, from 1989 to 2020. The death rate from breast cancer, the US death rate from breast cancer has dropped a whopping 43% from 1989 to 2020. That is over 450,000 breast cancer lives being saved. It is felt to be secondary to mammograms and better treatment. Mammograms, and I did say mammograms and better treatment. The bad news is, unfortunately, breast cancer is the #1 cancer killer for African American women. Unfortunately, I had a young lady I grew up with in my neighborhood who passed from breast cancer. Someone I was, good friends with in college, my neighbors in Michigan, on and on and on. African American women have a 40% higher death rate than white women from breast cancer. The difference is multifactorial, complex, and there is conflicting data. An excellent review article was published by the University of North Carolina. There is biologic, social economic, and treatment differences in reference to breast cancer for African American women and white women. The biological difference is that more women are diagnosed at a younger age, more African American women are diagnosed at a younger age than white women. More African women have what's called triple negative breast cancer, which has a overall poor prognosis. And we are treated differently. We live far away from tertiary cancer centers. We're less likely to get what's called a sentinel lymph node biopsy. We're less likely to get a lymph node dissection. We're less likely to be offered or receive life-saving hormone therapy, less likely to be offered or receive life-saving chemotherapy. There is evidence that suggests women across all racial groups, if they receive equal treatment, equal outcomes follow. So that 40% difference is partially from poor treatment, partially from biological differences, and partially from social economic differences. Black, white, and Hispanic groups have approximately equal mammography rates. Black, white, and Hispanic groups have approximately equal mammography rates. The main reason women don't get screening mammograms is a lack of health insurance. The main reason women do not get screening mammograms is a lack of health insurance. So for all women who don't have health insurance, they get a yearly mammogram at a rate of just 40%. Women who have health insurance, they get mammograms at a rate of 70 to 80%. And that's a big difference. Last but not least, prostate cancer screening. Average risk men should be screened at age 50. African American men should begin screening at age 45. The greatest benefit for prostate cancer screening is between the ages of 55 and 69. Routine screening is recommended for every 2 years. The American Urological Association does not recommend screening for men who are over age 70. I think, as people are living long and longer, hopefully they'll begin to modify their recommendation to be analogous to the breast cancer recommendation, in that if your life expectancy is less than 10 years, then it's very reasonable not to be screened for prostate cancer. But if you're a healthy 72-year-old or 75-year-old, in my opinion, and some cancer experts, it may be very reasonable to continue with prostate cancer screening. In 2012, the U.S. Preventive Services Task Force recommended no screening for prostate cancer, no PSAs done for prostate cancer. That was recommended in 2012 by the U.S. Preventive Services Task Force. They came out with this recommendation because of data that, in my opinion, and some other experts, was substandard. So it was basically studies that were done in screening men and men who were randomized to not be screened. But if you look at the data very carefully, men who were randomized to not be screened, a good number of those men were screened. So it was kind of faulty data. So that led to the American Urological Association disagreeing with the U.S. Preventive Services Task Force. And in 2018, the U.S. Preventive Services Task Force modified their recommendation to be in line with the American Urological Association. So from 2012 to 2018, they recommended no PSA screening. So by the time they changed their mind, some damage had already been done. So in 2017, 27,700 men in the United States died of prostate cancer. In 2022, unfortunately, 34,500 men died of prostate cancer. And the speculation is that could have partially been because of that window of no PSAs being done. The prostate cancer mortality rate from 1992 to 2017 went from 39 deaths per 100,000 men down to just 19 deaths per 100,000 men. This is believed to be secondary to PSA screening and better treatment. There's something new on the horizon in reference to prostate cancer screening. This is out of the United Kingdom, and it could be, and I say could be, a game changer for screening for prostate cancer. It detects specific chromosome abnormalities in the blood. It is called a PSE test. It's called a PSE test, and it just needs to be studied in larger trials. It needs to be studied in larger trials. Thank you. It has been my pleasure, and please ask me questions. Thank you so much.
All right, give me just a moment while I look around to see if there are any questions. I'll hand it over to Ms. Val, and if there are some, I'll raise my hand for them.
Okay, well, thank you so much, Dr. Littles, for that informative session. A lot of information pertaining to lung cancer, breast cancer. And you mentioned the third hand smoking. I was going to ask you about secondhand, because we hear that quite often, but third hand was enlightening. And we do smell, smoke or the cigarette, the scent on people in houses, several places that we go. So that is very interesting.
If you're smelling it, you're getting it.
Wow.
There are some questions here, Ms. Val. I have a raised hand from Pete G.
So let me say this first. If you would like to speak with Dr. Littles, then just raise your hand and you will be acknowledged. If you do not want to speak, you can just drop your question in the chat and we'll read it so that he can answer it for you. Thank you so much. Thank you. So we have a question from Yolanda Faye Brownstone, and it is, are we participating in the needed trials?
That is an absolute great question. The answer is no. And that's for a plethora of reasons. One is there's a paucity of African-American physicians that are offering trials. So if our people usually, go to tertiary centers and are asked to be involved in trials across the country, most of the people that are having conversations with us don't look like us. And there's a lot of mistrust there in reference to trials. But I will say there's a lot of data that says that, for example, in prostate cancer, African-American men that are treated for prostate cancer under NIH-sponsored trials live as long as white men that are treated in those same trials. So, and the same thing for breast cancer. There's NIH-sponsored breast cancer trials that people have reviewed the data, and Black women treated on trials live as long as white women treated on trials. So the same for prostate cancer. So there are a lot of advantages in enrolling in clinical trials, but there are very few of us that are enrolled in trials. That's a great question.
Next question. Do you recommend the 3D screening for women when you have a mammogram?
Absolutely. 3D mammograms are certainly state-of-the-art diagnostic tool for mammograms. Most institutions across the country, most large institutions across the country have them. 3D mammograms are very helpful.
Awesome. Next question. When will PSE be available in the US?
Oh, that's a great question. So PSE is, the trial was out of the United Kingdom, and it was just around 150 patients. So I would, guesstimate, the first step is to put it in a trial, in a larger trial, looking at, 50,000 men or 100,000 men. And they may open up the trial in the United States and some tertiary centers or NIH-sponsored trial. It may be a part of a trial, maybe hopefully 2 to 3 years from now. And, men will have, men and hopefully African-American men will have opportunities to participate in that trial, hopefully 2 to 3 years from now, maybe even sooner. Then once the trial comes out, then if the trial is a positive, as the preliminary trial was positive. So when a preliminary trial is positive, it hypothetically is something positive coming to the horizon. So theoretically, it could work out. But the larger trial may find that the PSE is not the panacea that we think it is. So I introduced that as something preliminary. It's certainly at this time not the standard of care, because the initial trial was a company-sponsored trial, and it was I think around 150 patients. So too small a number to be close to being the standard of care. Just hopefully over the next 2 to 5 years, we'll have a large trial to come out, and hopefully more of us will look at enrolling in that trial and then go from there. Great question.
Next question. What would you recommend for females with dense tissue in their breast?
Females with what now?
Dense tissue?
GIST?
No, DENSE.
Oh, dense.
Mm-hmm.
Yeah, so that is interesting, because there's a school of thought, and I think a lot of primary care physicians or breast surgeons are moving those patients to 3D mammograms and perhaps MRIs. But the big issue, the big disadvantage in MRIs is that it has a high false positive rate. So there are a lot of suspicious things, but I think there's a movement toward women with dense breasts combining 3D mammograms with MRIs. And I believe that's a reasonable step, but that step comes with the disadvantage of the specificity of mammograms in reference to breast cancer. Great question, though.
All right. Man has colon cancer. Pre-cancer is polydetected. What is the next step?
You said a person has colon cancer or just a precancerous polyp?
Excuse me, I'm sorry, I read that wrong. Colonoscopy, I'm sorry. Man has colonoscopy, precancerous poly detected. What is the next step?
Yeah, so if it was indeed what's called a precancerous polyp, most gastroenterologists will recommend, or surgeons will who do colonoscopies would recommend screening colonoscopies be moved from every 10 years to every 5 years.
All right. Let me check on Facebook to see if there are any questions. Any other questions in the chat? I don't see any additional questions right this second. I do have a question. Being a part of the 40 and under crew here, I have a question about smoking hookahs. How much of a contributor is that to cancer, just like smoking cigarettes? Is it on the same line, or?
Smoking what now? I didn't hear you.
Hookah?
Smoking hookah?
Yes, sir.
No, it's a great question, and I'm afraid I'm too old to know what hookah is.
Okay.
I love it.
I missed I'm not a part of the hookah generation. I'm sorry.
I got you. Oh, what about the walking, what are they called? The things that people are walking around with in their hand.
Talk about the e-cigarettes?
E-cigarette, basically, but it's not a cigarette. It's a hookah in a cigarette form almost.
Yeah, I'm familiar with e-cigarettes. I can't tell you anything about hookah. I feel real bad. I know I'm old, but I can't tell you anything about hookah.
It's okay. We do have another question here. Can you explain the difference of urine colors and the meanings?
Urine color?
Yes, and the meaning of what the different urine colors mean.
Well, I think the first thing comes to mind for me, dark color urine. I think historically, the darker your urine is, the more dehydrated you are, and I can certainly say that dehydration is a hidden danger for the elderly, and so is caffeine. So the older because caffeine is a diuretic and it will lead to dehydration, especially in the South with hot temperatures. And so the older we get, the more caffeine is no longer your friend. So dark color urine can let you know that you're dehydrated. Blood in your urine can mean a number of things that don't have anything to do with cancer, but certainly blood in the urine of a cigarette smoker needs to be evaluated because cigarette smoking can certainly lead to bladder cancer. So there's blood in your urine and changing color in your urine from urinary tract infection, changing color in your urine from dehydration, and of course changing color in urine from blood in your urine. And there are a number of things that can cause blood in urine, from kidney stones to bladder cancer to just small kidney stones that are passed on their own. But the key thing is the older we get, the more the dehydration becomes an issue. And that's why the older you get, caffeine is no longer your friend, in my opinion.
All right. Any other questions, you guys?
I've got one. Dr. Littles, Hank Allen, you talked earlier about low dose cancer screening, lung cancer screenings.
Yes.
How do you encourage physicians to offer that up as an option?
Well, I think a great question. So I think because the screening rate is at 6%, it just takes a lot of medical education. So what I do generally is I may see Johnny for his prostate cancer, or Beth for her breast cancer, or anal cancer or colorectal cancer, and they would qualify for a low dose CT scan. After they finish treatment, I will contact their primary care physician and remind him or her that Mr. or Mrs. X is a candidate for the annual screening, And they just don't, unfortunately, they just don't think about it. And the general public needs to be aware of that, because you need to be your own advocate. And once again, knowledge is power. So I think that not many healthcare providers actually think about the low-dose CT scan, and not many patients are aware that they are candidate for the low-dose CT scan. So patient education and community education is, and the public education part is what we're doing now. A lot of work to be done, for sure. Thank you, Hank. I see my cousin on the Zoom, Ms. Mary Smalls. How you doing, fam?
We have a few out there on Facebook as well. I'm gonna go ahead and turn it back over to Ms. Val. I don't see any other questions right this second in the chat.
So
Val?
as we turn over to Ms. Val, the question I would ask you, Dr. Littles, is there any question that you hear that we should be asking but haven't asked yet? Is there a question that we should be asking you that we haven't asked? Something that we should know about? From being African American, being maybe seasoned or not as seasoned when it comes to cancer?
I think the big myth. Oh, a couple of things. Now that you mentioned it, a couple of things I see in our community. One, the myth of if you have surgery and you get opened up and the air hits it, the cancer spreads. There is absolutely no truth to that myth. No truth whatsoever. No truth whatsoever. And the other one is, don't take that chemotherapy. Don't take that chemotherapy. Don't take chemotherapy. And to the latter, I will say that God would have not let man discover chemotherapy if it were if it was for only non-Christian people, or it was for only non-African American people. Chemotherapy, immunotherapy, hormone therapy, I've seen it do phenomenal things in reference to cancer care. I would also recommend in 2023 that we only see board certified physicians. We only see board certified physicians. The other thing, now that I think about it, and this is unfortunate, but there are a number of people that look like us that will not go see African American physicians. Now, here's what the literature says. African American people live longer when they have African American physicians. Not a lot of people know about that. Not a lot of people, some people may not even believe that, but that's what the literature bears out. So we can be hard on each other, but that is what the literature bears out. So these kind of myths that I've heard and biases that I've heard, there's just no truth to that. Thank you so much.
We actually have another question and then two other hands. One question.
From my drum major. I see the hand from my drum major.
Okay. Well, one of the questions is, what about cigar smoke?
Yeah, that's a great question. It appears that cigar smoke is unhealthy, but is not in the league of cigarette smoking. Cigar smoking is unhealthy, but it is not as lethal as cigarette smoking. Every minute in this country, somebody dies a cigarette death. 1,200 people a day die from cigarette smoking. That's from cancer, heart disease, and stroke. Every minute in this country, somebody dies a cigarette death. So cigars are unhealthy, somewhat very unhealthy, but it is not in the league of cigarette smoking. And neither is pipe smoking. Unhealthy, but not in the same league.
Okay. Latoya?
Good evening. Thank you for your information. My question is really about a different type of cancer and the screenings for it. Recently, I was diagnosed with leukemia, but there are no specific screenings. I wasn't sick. So are there screenings that we should be aware of for leukemia?
Great question. The short answer is no. However, annual physical exams with complete blood counts can give you a indicator that something is amiss. So there are no official screenings, but you can be detected with complete blood count abnormalities, can pick up things that can lead to that diagnosis. So the short answer is no, but annual physical exams with complete blood counts can show things at its asymptomatic point.
Good point, because that is how it was found. It was in routine blood work,
Yes.
but I didn't know if there was. I mean, I guess that is the screening when you do your blood work or your annual physical, which is extremely important, as well as knowing about. I know years ago when I was first coming out of college, and they did a Be the Match drive, not really understanding that African Americans need to donate that bone marrow. We're underrepresented in that way, and that was the other thing that, having gone through it now, I realize that is what helps to save us, and that we should be more aware of that, the Be the Match drives.
Awesome. Okay. That Mr. Amaker next.
Drum major.
Drum major.
First of all, Dr. Little, let me thank you for such informative information, and congratulations. As always, does my heart good to see a 101 member cutting up, and you are definitely cutting up. With that being said, that was my question initiated about cigar smoking, and I think you answered that certainly to my satisfaction. And I'm very pleased to be a part of this very informative platform on oncology here this evening. So bless you as you continue with this, and we bless you to be a blessing to us, your alumni, and many others. Thank you so much.
Yeah, you're welcome, man. Yeah, I certainly have great memories, fond memories of you, man. God bless you and your family, man.
Thank you.
All right, our last question here. If a man had and survived prostate cancer, what is the recommendation for continued PSA screening?
So it's not really screening at that time. It's called follow-up. And so after you're diagnosed, because I've treated over 1,500 men with prostate cancer. Oh, that's the other thing I want to say. Thanks. I'm glad that question came over. It reminded me of something else I wanted to mention. But after people have been definitively treated for prostate cancer, in most cases we order yearly PSAs for the rest of their life, because medicine is evolving very, very rapidly, and there are outstanding what's called salvage treatment options for men who recur after definitive treatment for prostate cancer. So there's one other thing I want to say, and I think this is very, very important. If you're diagnosed with prostate cancer, and I would say this because never say never, but I will say never. If you're diagnosed with prostate cancer, never, ever, never get definitive treatment without talking to a surgeon and a radiation oncologist. So don't allow the surgeon to talk to you about radiation, and don't allow the radiation oncologist to really talk to you or bias you about surgery. Make sure you have a comprehensive discussion with both specialties before you make a decision. Because as medicine is evolving, there are a number of ways to treat early stage prostate cancer. And you want to be fully educated before you make up your mind about definitive treatment. So never get treated for prostate cancer without talking to a urologist, or maybe more than one urologist, and a radiation oncologist, and maybe more than one. So take your time and make the right decision for you. And also never be afraid to ask your doctor questions. Whenever I see my cancer patients, I create an environment where questions are fostered. So if he or she doesn't like questions, that's a bad sign in 2023. Thank you so much.
Any additional questions? Well, if not, thank you all so much for your questions. Thank you, Dr. Little, for your time. I know that you are oh so busy, but thank you so much for sharing with us. And it's always great to know that we have bulldogs out there making a difference for not only our community, but for the world. So thank you so much. And thank you everyone for your attendance. One thing I want to remind you all is that if you have not signed in, there is a link for you to sign in to show your attendance. The next thing is we're looking at doing these health sessions quarterly for right now. In June, and we don't have the exact date just yet, but there will be something going out very soon with that date. And we're going to be talking about dementia. We know so many people who have dementia or have had. And some of us have been caregivers or are currently caregivers of those with dementia. And so Dr. Macy Smith, who's an alum, and she's also a board of trustee member, will be bringing that information to us in that session. Moving forward, if anyone on this in this webinar has a topic that they would like to discuss, and or if you know someone who could bring some valuable information to us in terms of health and wellness, please let me know, and I will drop my email in the chat so that we can keep these series going. If you think it's valuable, then please in the chat, just drop a 1 to let us know if you think that what we did tonight is valuable. And I'm going to put my email address in the chat. Okay. So if not, please send me an email. Like I said, if you even think of, well, thank you. I see someone's coming in. So that's great to know. We want to make sure that, not only are we taking care of South Carolina State, our dearly beloved alma mater, but we also have to take care of ourselves in order that we can continue to take care of her and all of the students that that are there in attendance. So thank you so much again, Dr. Littles. And we're going to close this session out as we do in church. We don't have an offering, but we do have a closing prayer. So Reverend Barnes, Barnes McLeod, she is a newlywed. So we got to get used to adding McLeod, but Reverend Barnes McLeod, would you give us a benediction, please?
Yes, I'm so reminded of what we do in church. So thank you, Val, for reminding us that, God is the source of all that we do here.
Yes, ma'am.
So let us pray. Almighty God, we started this health session with you, and we are closing it with you. Oh God, we give you thanks for Dr. Littles and for the information, oh God, that was shared. Help us not just to be hearers, but to be doers, oh God, that our lives will be more fruitful. We thank you for the vision of this health series, that it will help us to be better people. God, we give you thanks for this great association, for the commitment of our loyal sons and daughters, especially, God, those who will continue to serve and provide information. Now, God, I pray that as we go forth tonight, that we will have restful sleep, that our bodies will be revived and renewed. And God, it is our prayer that you will allow us to rise in the morning to go about the activities that you have assigned to our hands. Oh God, help us to always know that it's in you that we live, we move, and we have our being. So thank you again for this great opportunity to share and to receive such valuable information. May the Lord bless us and keep us until we gather again. Amen.
Amen. And until we meet again, Bulldogs, stay strong. And thank you so much. Have a good night.